Okay, we'll get underway. So welcome everyone to the third and final of the Menzies Youth Type 2 Diabetes Case Study Series. Today we're going to be talking about young adults. As always, I'll start with an acknowledgement of country. So I'd like to start by acknowledging the traditional custodians of the lands on which I stand. Here in Cairns, that's the Gimli Wallabara Yidinji people. And also welcome all the traditional owners of the lands on the many locations that people are joining in from today. Acknowledge the important role that Aboriginal and Torres Strait Islander people play in the work here done at Menzies. So, as always, we're going to have 3 case studies today, and we're going to spend about 15 to 20 minutes on each of these case studies. The case details are going to be presented, and then we're going to have a discussion as a panel. What we're going to do differently today is, in response to some feedback that we've had, the case details are going to be presented by Dr. Eleanor Ellis. And what she's going to do while she's doing that is talk you through the different information that she's looking for and her clinical reasoning around which values she gives certain significance to and how that might sway her clinical reasoning or the direction that she goes with treatment. So I'd encourage people, as always, please type in your questions to the question and answer box. And if you've got any questions while Eleanor's going through the case details, please put them in. I will ask them to Eleanor as she's going so that you can get that insight into what a specialist is looking for when they're going through this information. So today on our panel, we've got Dr. Emma Griffiths. She's a GP at the Kimberley Aboriginal Medical Service. We've got Cheryl Sanderson. She's a diabetes educator and registered nurse at Malala Health. We've got Jamie Anderson. She's a diabetes educator and pharmacist working at Worlinjang Health Service. And finally, we've got Dr. Eleanor Ellis, who's an adult endocrinologist and director of endocrinology at Alice Springs Hospital. As always, the information used in these case studies, it's de-identified. It includes both factual and fictional information in order to highlight the important aspects of care, but also keep any confidentiality of the de-identified information of those participants kept confidential. So we'll move on to case 1. So Eleanor, if I can pass this over to you now to just read through some of these figures here, and perhaps you could talk us through a little bit about, if you're seeing this in the clinic, what are you thinking about when you see this?
Okay, thanks, Damien. So just looking at the first page here, so things that we need to take into account when we engage with this young person and determine what what treatment options and sort of social interventions or supports we consider. Then the first one that stands out here is that this young woman lives quite a long way from a major center, so it's a remote area. So we would definitely then think of ensuring that primary care, are key players in what we try and achieve. So she's had diabetes for about 7 years. It's poorly controlled. She's got a number of clinical features there that support insulin resistance and support type 2 diabetes. Her type 1 antibodies are negative, so we should always think about doing type 1 diabetes antibodies in young people, even Indigenous people, and even if they're overweight, because a large proportion of the world is overweight and obese these days, and it doesn't preclude them from actually having type 1 diabetes. We've got to take her mental health history into account here. So she's a vulnerable young lady. And then we can see there's an extensive family history of type 2 diabetes, which may be beneficial for us when we engage with this young lady, because she may already have someone that she can rely on as a support, or someone who, she may already understand something about diabetes. But on the flip side, it might be, you know, everyone has it, I'm not going to worry about it, or everyone's going to end up on dialysis, so, you know, why should I make any extra effort? And then there may be some shame and sort of guilt involved there as well. And perhaps for her mother as well, because she, you know, she'll be thinking about the children that she's now had who have diabetes. So there may be some guilt and shame in there too. So what this slide shows us, she's remote, poorly controlled diabetes, a vulnerable young person, and probably not that engaged with her healthcare. Okay, so she's been prescribed what you'd expect over the course of time. So most of you will know that metformin and insulin are the sort of only approved medications for young people up to 18. Although we have been using GLP-1 analogs off-label for quite a long time, and there are some internationally approved GLP-1 analogs for this age group. The glycoside is a medication we're not that fond of in this young age group, because there is a little bit of evidence that supports perhaps that it accelerates beta cell loss. I'm not sure how strong that evidence is, but I try and stay away sort of from glycoside if I have a choice. And then hopefully she wasn't on, she wasn't on linagliptin and dulaglutide at the same time, which is good, because they're sort of the same family of medication. But you can see quite a lot of, you know, people have tried quite a lot of things. And looking at her chart of her glycemic control on the right-hand side there, and it's supported by the comment that she's got sort of little connection with any health professional since diagnosis. But you can see that she has intermittently, for a short period of time, maybe taken her medication with quite a drop in HbA1c, but then that all falls over again and the HbA1c takes off towards the sky. What's happened recently, I don't know. There was quite a drop from 16 to 11. When I see that, I do wonder about acute renal issues, which I don't think has happened to her, but, you know, she may have become quite motivated there in a short period of time, or been in hospital for a short period of time. So I don't know how to explain that, but overall, quite poor control, and overall not really taking her medication that much. Okay, yes, so obviously we want to know about complications, and based on this, she has got quite significant proteinuria. Fortunately, her creatinine is still normal. No other complications from her diabetes that I can see there. She's got good blood pressure control. So for someone with that degree of proteinuria, we'd be aiming for under 120 over 70. And then she's got quite high triglycerides, but those may improve as her glycemic control improves. Her current medication, so she's on 3 medications for diabetes, and I'm presuming she's been able to source the dulaglutide, because, you know, you all know that the GLP-1 analogs have been nationally in short supply. So the combination of metformin, empagliflozin, and dulaglutide don't actually meet PBS criteria, so we do not have any diabetes PBS criteria where you can use empagliflozin and dulaglutide in combination. But of course, the SGLT2 inhibitors like dapagliflozin, we can now sometimes get on renal criteria, which she doesn't meet, and also cardiac criteria. So, but anyway, that is a good combination for her. And why do I think so? Well, she has got quite significant proteinuria. So I would want her ideally on medications that delay progression of renal disease. So what have we got there? We've got the empagliflozin, we've got pretty good evidence that it does. The dulaglutide less so. And then, of course, the ramipril. And then she is on quite a high dose of atorvastatin for her dyslipidemia, and then some other medications for amlodipine. And I'm happy to see that there was the Implanon as well. But you prefer to avoid an sort of unplanned pregnancy here. Okay, so many cardiologists in Adelaide would tell you that a woman of 20 is not having an MI. Well, they do have MIs, and here is proof of that. Alcohol may be an issue for her as well, and she now has an ischemic cardiomyopathy with heart failure with reduced ejection fraction. And then once again, you know, we're going to talk about medication, but an SGLT2 inhibitor would be really good in this case. So in summary, she is a young woman who's had diabetes for 7 years with poor control overall, complicated by significant coronary artery disease, proteinuria. She smokes, she has high triglycerides, and she's struggling to we're struggling to engage with this young lady. So as all these cases, this is a challenging one.
Thanks, Elna. That was really interesting hearing you go through the case details there. Just going to pass over to the other panel members here. So Emma, I've got a question for you. She lives a long way away from a major centre, and it's probably pretty likely that she's going to be managed by a GP here. Can you talk us through a little bit about what you're thinking as a GP in primary care when you see a patient with this type of history?
My instinctive thoughts in complex cases like this is that continuity of care is going to be the single most positive contribution we can make to her as a healthcare service. So I would be thinking of assembling my team of experts that I can consult for any complex management decisions. But I would be, I think the value of seeing the same person regularly would be probably contribute the single most important thing to her. And in remote areas, it could be a general practitioner, but I think you'd have to try and empower situations where it could be an Aboriginal health worker as well, having the face-to-face contact and giving that, for example, Aboriginal health worker or nurse or chronic disease nurse or diabetes educator, or that the person who's there to provide the care and support, what they need to make regular contact, and then look for incremental ways to reduce risk. So we have identified, of course, that she has suboptimally controlled diabetes. She's at very high risk of progressing to dialysis, as we have mentioned, and also of having adverse cardiovascular outcomes. But we don't know at the moment if she's taking any medication regularly, and we don't know what diabetes education she's had in the past. So we need to start where the patient is, spend some time and try to make incremental benefits that also, I think, enhance the patient's agency in decision making. And I think in remote medicine, it's all about calling and getting the advice you need for if it's a question of investigations or medication management. And I think GPs are often in situations where they have to take on situations like this.
Thanks, Emma. That's really interesting to hear. I'll pass over to you, Cheryl. As a diabetes educator, how are you viewing this case and what are your priorities?
Yeah, so it is quite a complex and difficult case, and thinking in the future to transition to the adult team. So often when people are younger, they might get highlighted, but they can get lost when they transition to adulthood. But I would be relying on a GP or because it's a remote area nurse or chronic conditions nurse or team to be referring to me, so I can pick that up on the data system. I'd also be doing my own data report to pick up complex cases too. So I'm not just looking at HbA1c, I'll be like doing a file review. Sometimes that might come in the form of in Communicare, a first-time diagnosis, or I'm not too sure about PCAS. The traffic light report is definitely where I'd pick up. And then I'd be putting them as priority on my list and recall for when my visit is out to any of these small communities. So I want to make the most of, so my list is sent out to the communities before I arrive. And yeah, then it's game on, right from the beginning, to try and get this person to make friends with, to start with. So it really is trying to connect and build a rapport. So all of these things take time, and then trying to make sure that they are in good contact with the GPs. And now they could be fly in, fly out GPs, and especially these remote communities. So that's emailing through PCAS and putting priority recalls on that are often printed out in the mornings, particularly when I'm there, if I set the date like that. And then also like planning complex case conferencing. So that's part of my plan too, is to get together with the GPs beforehand or while I'm there, saying I want to do a case conference with particularly complex ones like this. Personally, when I take young people in or try and get young people in, it's really about trying to build a rapport and see what's important. So that can take a while to go through, and you know, be really grateful that they've taken the time to come in. And that could include me going and doing a home visit and taking either an Aboriginal health worker with me or an Aboriginal transport person with me, and perhaps going and find, if it's younger than the younger age, then I'll try and get a family member to support me in getting this person. So yeah, I might go through a lot of stuff, but she's particularly complex, especially with the cardiomyopathy already, and yeah, very difficult, but looks familiar to me, like a case that could be quite familiar, and just so very young.
Thanks, Cheryl. Jamie, I'll pass over to you. With your background as a pharmacist, looking at that, she's on several different types of medications. Would you have any input from your pharmacy background on how we could help with adherence to medications?
Whenever I talk to people about why they don't take their medications, it's never that they don't want to take them, it's that it's just not a priority. So I'd be looking at what her social situation is, like is her housing stable, who is around her, like who can support her, what sort of connection she has with the clinic, whether they could give some sort of supported like medication administration services, you know, getting medications 3 days a week is better than no days, I guess. Rarely is it that they just don't want to take them, or if it is that they don't want to take them, there's a reason behind it, like they don't think there's any point, or it's not just that they're choosing not to, it's just they've got so many other things going on in their lives that it's just not a priority. Just have a fridge to keep medication in, that sort of stuff. They're all factors, and you'd be wanting to look at all of those as a way to help her adherence.
Thanks, Jamie. Elna, I'll pass over to you here. When you had a look at her medication and how things are being treated, is she on optimal therapy right now, or is there anything else that you'd suggest prescribing?
I looking at her medication, so I've already said ideally we would want her on a SGLT2 inhibitor and metformin. And the reason for the SGLT2 inhibitor is cardiac and her renal disease, her albuminuria. But of course, those two medications are really not going to achieve optimal glycemic control because the SGLT2 inhibitors only lower your HbA1c by about 0.5%, and metformin about 1%, but can be more. So you can see she needs a lot more treatment in addition to that. We can get past, our lovely GP might tell us how they can get past this, but there is the S100, or also Jamie, who's a pharmacist, there is the S100 clause where we can prescribe non-PBS combination medications for young people or for Indigenous people in that sort of closing the gap motivation. So, and I think SGLT2 inhibitors, GLP-1 analogs are really good combinations to what, the metformin and the SGLT2 inhibitor, because A, they're really effective. They can lower your HbA1c by up to 1.8%. B, it's a once a week medication. So if she's able to, get to a clinic, if she doesn't want to do it herself, if someone can get to her once a week, that's something quite easy to administer. And of course, it too has cardiovascular benefits. And so my view would be to try and go with those three medications first, and then see, where I get to in terms of glycemic control, and then consider whether I'd need to add anything on top of that.
Thanks, Elna. Emma, have you got anything to add there?
Without saying the wrong thing, S100, of course, is a different funding stream, and we certainly do use, I certainly have seen that combination of medication used under the S100 system. And Jamie, I don't know if you've got more to add in terms of just the specific access to that combination.
It's not technically that it's allowed, it's that they couldn't find out if you were doing it. So a PBS script is Medicare claimed against a person, S100 is claimed against a clinic. So, there'd be no way for them to determine which meds were going to which person. So it's kind of more that they just don't look, so they don't see.
Yeah, so we see this combination used quite commonly in our Indigenous mob, whereas in our non-Indigenous population, we have to be a lot more careful about how we prescribe things. And it's just because they're expensive. They're really good combination, but it's just that they're new drugs, they patented and they're expensive. And so that's why there are the PBS restrictions.
Yeah. It's expensive to give medications that no one ever takes as well. Whereas, of course, the advantage of dulaglutide is often that doses reach the patient probably at a much higher rate than Webster packs that can pile up. So I'm ethically okay with it.
That's a good point. Thanks, Emma. I'll pass over to Cheryl now. Have you got any other suggestions here, Cheryl? We've talked a little bit about medication adherence. Have you got any other types of strategies that you use with clients that might be similar to this to support adherence?
Yes, well, just in regards to who else should be involved in her care, definitely if there is a pharmacist available, having time to go through the medications, because ever since having her cardiac event, it says in here that it's really dropped off with her adherence. So it's probably, depression, anxiety, just not feeling very happy about life in general. So definitely if there is some kind of like social worker, counselling available, trying to get her linked in with social emotional wellbeing. Because if you don't sort that out, then I guess nothing else is really going to matter. If she's feeling sad and down and just like, this is my path and, you know, that's it. But if who else can get involved in her care, trying to get her linked in as much as possible with the clinic, and what other services they might have. So yeah, if there is a weekly Trulicity, there are some patients that have already been started on weekly Trulicity. That is an opportunity for a weekly check-in. And often that could be done in outreach, or it could be come into the clinic, and that kind of can build a bit of a bridge or a bit of a link. But yeah, cardiac wise, I'm not sure about cardiac rehab type of things in very remote communities, but I'm sure they're difficult, but they are proven to like reduce poor outcomes after a cardiac event. But yeah, it looks like there might be, you know, social emotional wellbeing, and it depends what services are in the clinics and what are available. Tobacco action workers, the quit smoking, there might be AOD worker. Yeah, so I'm often just looking at the whole picture and seeing what, you know, meeting the person and seeing what's going on, and finding out from them, and then being a bit of a traffic director and going, would you like me to try and put you on to this person to check in with you, and can I see you next time I come here, and can I arrange for a doctor to see you, and just gain some trust.
I'll just pass over to the rest of the panel just to finish off. Any other comments on how you'd manage the comorbidities in this case?
In view of her proteinuria, I would also make sure to spend a little bit of time on trying to prevent any future acute kidney injury. I've noticed she was having recurrent skin infections, so making sure we get on top of those early is important. Encouraging hydration, especially on the SGLT2, making sure she's drinking plenty of water, and probably go over some sick day management with her medications, including coming in, if it's a remote clinic, coming into the clinic early whenever she's unwell, so that consideration can be made for temporarily withholding them.
Thanks, Emma.
Particularly the SGLT2 inhibitor, right? Yeah, because of the small risk of euglycemic DKA, which is higher in that acute illness phase. Yeah. Yeah, so I wondered, you know, the sort of proteinuria and poorly controlled diabetes, and if I remember correctly, she was also overweight. So just about, you know, beverages, what kind of beverages she's consuming, high sugar beverages, and then also encouraging the smoking cessation. You know, just some talks around that.
Definitely. Thanks, Eleanor. Jamie, anything from you finally?
More just looking at her social supports, and you know, the best way to manage her comorbidities is medication. So how can we work on that, get her life a bit more stable, so medications are more of a priority.
And Cheryl, any final thoughts?
Yeah, Jamie's right. Just trying to get the medications adherence, and perhaps looking deeper into the reasons why they're not being taken, and then just add from there, I guess. Definitely smoking cessation, and diet is always a huge one. Trying to look at the diet, then going over to the shop and visiting what the community shop might be looking like, so I can give advice that is compatible with what's available to people. So often I'm going up to the shop and having a look, and then, you know, just finding out what's the diet looking like without being judgmental, and that's the reality. And looking at swaps, simple swaps, trying to like swap the spaghetti for baked beans, and it's like, yeah, and you know, there's little things that you're trying to help people with, so they can feel good, like feel okay when they walk out. I don't want people walking out of a consult with me feeling this is terrible, it's, no, it's awful, I feel bad, because you're just going to go and get a can of Coke. So you want to give people some sort of positive, some goals, some SMART goals. So looking at something that's specific and measurable, realistic.
It's a really good point, Cheryl. Excellent. We'll move on to the next case. So Elna, if you would go through the details of this one again for us, that'd be great.
Okay, so hopefully I didn't do it too much on the first one and left enough for discussion. So this is a 23-year-old young lady living in Darwin, diagnosed with diabetes 11 years ago, most recently poor glycemic control. She's got microvascular complications, and she has a significant loss in terms of her obstetric history. And I mean, that must have been so hard, losing her first baby through stillbirth at 38 weeks, and then a number of other miscarriages. She has 2 live births. So I would assume that the obstetrics people had, you know, looked into possible causes for that other than poorly controlled diabetes. But if they hadn't, then certainly I would be testing her for things like lupus and lupus anticoagulant, and I'm not going to go into what else, but and then to determine how much of that may have related to diabetes, we need to find out from her and also from her medical records what happened in that situation, and what did they attribute those losses to. Okay, so far we've got a young woman with poorly controlled diabetes with microvascular complications. She is prescribed medication, but she's not taking it. So obviously, if someone is really set against not wanting metformin, then we shouldn't keep pushing it and find some alternatives. And then looking at her microalbuminuria or albuminuria, it's no longer microalbuminuria, it's macroalbuminuria. She is really not on any medication that has been prescribed to actually delay progression of her renal disease, like once again an SGLT2 inhibitor and also an ACE inhibitor. So she's on the Depo-Provera, and which she doesn't want to take, and she's really quite interested in having another baby. I think it's mentioned maybe on the next slide. She's high functioning. She's got a full-time job. She's got a new job. She lives with her partner and 2 children, but she's had more trauma in her life. Her father passed away, and so that led to her discontinuing all her medications. She's quite high cardiovascular risk because she smokes and with that proteinuria. And then there's a lot of people in her family who have diabetes, including her older sister, who may be potentially a support for her in the situation, as we mentioned previously. So that's where we're at. So she has microvascular complications, not taking medication, not on the correct medication, or the most appropriate ones. And then she's had some losses, huge losses in her life. And I think the next slide might be the one that says she's desiring another pregnancy. Yeah, so she really wants to become pregnant and looking at her glycemic control, it too has been up and down, suggesting she may have taken medication intermittently at times, but overall quite poor control. Blood pressure is good, and yeah, she's desiring a pregnancy, and then had some hypo symptoms occurring at normoglycemic ranges, which, as you know, can occur if their glucose levels are corrected quite rapidly. People can have those symptoms, and I'm wondering whether that may have related to the glycoside that she was prescribed. So yeah, so we need more information about her situation, and obviously some discussions with her to find out, what might have happened, and talking around, the risks and etc. of pregnancy, and how to progress there, which will be some of the discussion points.
Okay, so I might pass over to you again here, Eleanor. So we've got the case here where the main priority is to become pregnant. How would you respond to this?
So I think first I'd empathize. I'd want to show some empathy in the, just try and, with the losses that she has had. And then just very lightly explain that, and find out, during those pregnancies, was she on treatment for her diabetes? Did she use insulin? Did she see, was she seeing sort of the people, we call it DANCE, diabetes antenatal care, but was there someone overseeing some of that treatment? Did she have supports? Just trying to work out how, how did she manage how was her diabetes managed, and how well did she sort of engage with it during those pregnancies? And then I'd explain to her that pregnancy right now, where she is actually really high risk for not just for a baby that she might have, but also for her own health. But I would say to her that, we can work on all these things, and we can improve your diabetes, and we can, we can work on all these things. And then when we get your sugars down, then it'll be a much, better time in your life to have that, consider that. So I might try and encourage you to have, one more depot, just so we can try and help her bring her glucose levels down.
And can I ask, Eleanor, have you got a target in your head that you're thinking at this level it would be safer to have a pregnancy?
Well, we know that 7% is sort of that number, because we know that if you're at conception, if your HbA1c is around 7%, the risk of miscarriage and congenital abnormalities is about the same as other members of the public. But it rises quite significantly after that. And when you're getting up to 10%, an HbA1c of 10%, we know that the risk is quite high, a lot higher. I'm going to quote, you're in the 12 to 15%. But of course, if that continues through pregnancy, then you have the other complications like the macrosomia and, the things that follow on from there. So 7% would be the number that you'd be trying to achieve.
No problem. Okay. So I think you've touched a little bit there on the second question as well. What issues do you want to address before recommending she try again to conceive? So you recommend another round of depot. Was there anything else that you'd suggest before her trying to conceive, aside from bringing her glycemic levels down?
Yeah, well, she's got retinopathy, so I'd be quite keen on her seeing the optometrist, because we know retinopathy can deteriorate in pregnancy. So if she already now has significant retinopathy that might need treatment, I'd prefer her to do that. And her proteinuria may get worse, but fortunately her renal function is still normal. So I don't think we need to be too concerned about that. So those are sort of all the medical things. And then what medication you're going to encourage her to take, of course, depends on, you know, how high you think the risk of pregnancy is within the next sort of month to 2 months.
Thanks, Eleanor. And who else are you looking to involve in her care?
Definitely quite a few people. So once again, I mean, she lives in I'm presuming Darwin, but she lives in a town. So once again, a service that could, or someone that could see her regularly, so that continuity of care. And of course, if that was Alice Springs, potentially that person could be me. But I would definitely want to involve an Aboriginal health practitioner if we have one, a DNE, anyone that she feels close to, or someone who can support her, like perhaps her sister, or I'd be guided by, you know, who she feels is someone in her family or her community, her partner, or someone who can support her in, you know, in taking her medication and just encouraging her on a daily basis. But I definitely, we don't have a lot of Aboriginal health practitioners, which is the problem, but we do have some ALOs. So, you know, even, you know, someone like that in the clinic when she comes to clinic, and have the educator there too. Yeah, so, and then with that, you know, there's losses. I'd have to see whether, you know, she's someone who engaged with, like our Congress here has a social and emotional well-being team, would she, you know, would she engage with someone there just maybe to work through the things that have happened to her and get some support there as well?
Thanks, Eleanor. I'll pass over to the other members of the panel. Have you guys got anything else to add here?
Again, it's important to look at that transition to adulthood, and that I just like to highlight that that's a key area. I think that sometimes we can lose trying to really get on top of things early. But also it's really important to look at that that family history. It's quite significant, quite a lot of trauma. Her father died recently, and the loss that she's gone through. And in regards to education about planning a pregnancy, acknowledging with empathy and engage, as Eleanor had said, and ask her about what her concerns might be, because I'm sure that she has got some concerns and how she might be able to set some goals. And yeah, let's work together to make sure that she has a safe, happy and healthy pregnancy and birth, is something that you would want to acknowledge with her, looking at, again, her diet, her smoking, stress, and then going over to her hypo symptoms and glyphosate. Is it related to food security, or is she just too busy at work? So she is high functioning and working full time. She has got a partner. What sort of support is she getting from the partner? I would offer her some glucose monitoring equipment to see if that might be something without it causing too much stress or worry for her, because sometimes it can go opposite, offering that sort of thing. Yeah, so that was pretty fast of me to go through that, but yeah, I'm sure I covered quite a bit of stuff there.
Thanks, Cheryl.
So talking about what Eleanor said about when she wanted to become pregnant, you know, having an honest conversation with her about what that will mean for herself and her baby and why that's a priority, and then moving on to how, you know, that might be a motivator to get things under control. You know, if she does get pregnant, she's likely to need insulin. So, you know, is that something she would consider starting now? But also looking at those social things around her, you know, her family and her supports, and what the implications are, and she's already had some losses. Like, does she have people around her to help her through another high-risk pregnancy? And how can we help her fight, you know, be motivated to manage her health through that?
Thanks, Jamie. Emma, any other thoughts?
Yeah, a few thoughts from me, partly based on some findings from our research in the Kimberley. I would be interested in discussing the potential of an implanon insertion temporarily for her. We found that the median number of depots women had in this situation was 1, and the risk of disengagement at this point is probably the highest possible risk. So obviously this is a very one-on-one conversation, but one of the things that can be recommended with implanon is the rapid return to fertility when you take the implanon out, whereas there is a uncertain duration of action of the depot, and it's also we found that it's a probably a placating gesture on behalf of patients when their agenda doesn't necessarily line up with the health professionals. So that's just one thing that we have come across in clinical care. The other thing is I would be starting folic acid today as important intervention. And I think one of the issues that I've seen with these cases is that there's a risk of, if we treat this person like we're anticipating a pregnancy early, we actually potentially miss the window for how we would manage her as a non-pregnant, non-about to conceive individual in terms of long-term risk reduction. So for example, if we're hesitant to use an ACE inhibitor in someone who has an indication for her proteinuria on the basis that she might be able to be about to become pregnant, and she doesn't get pregnant for 5 years or ever, then we may have gone down a journey of a different management trajectory, which is taking into account a lot of safety in first trimester concerns. But in fact, what we sometimes do is lose the long-term preventative health strategies that we would normally put in place. This is one reason why I like the implanon, because whilst the implanon's in, we can manage her as a person who requires preventative health care. And with the implanon out, we can implement our concerns about first trimester safety and medication choices. And there's a number of other things that she can do to reduce her long-term risk that are the same whether she conceives or not, like smoking reduction, maintaining a healthy weight, diet, which we can implement regardless of whether a pregnancy eventuates or not. So I think those are just a few nuances that I've come across, because this is quite a common scenario I've found, and one we have to assume that there will be a long consult at the start and ideally several follow-up consults to try and make a management plan that's acceptable for the patient.
That's some great points. Thanks, Emma.
Agree with
Although
your
just
points, Emma.
Eleanor, I think the ACE inhibitor would have been okay in first trimester at this point, so it would be, that's your understanding as well, is that right?
Well, I think as soon as someone's pregnant, we would stop it. But yeah, I think with her renal disease, she should be on it. Yeah, and yeah, just stop it as soon as she's confirmed pregnant. Yeah. And the folic acid is really important too, because of, because of her pregnancy losses, of course, more important probably than had she not had those losses. So that's really important.
just with her HbA1c too, it is quite high, 13.8. And like you said, Eleanor, first pregnancy, stillbirth, four first trimester and miscarriages. I would agree with Jamie to start looking at insulin and maybe even getting her started on insulin.
Yeah. I mean, if she said she didn't want it while she was on an Implanon, you could use other measures to get it down, like, you know, a GLP-1 analog, for example. She's going to need 2 or 3 drugs, but she'd have to understand that she's not going to get through the pregnancy without mastering insulin. Yeah, so I would recommend metformin and insulin right now.
Yeah, yes, agree.
Okay, we'll move on to the final case.
Oh, okay, Damien, there was just one question I had about this case. So this young person was diagnosed when they were 20, but I don't think the case told us how old she is now.
Is it a she?
Or a she or a he, I don't know. I think it's a she. I think it's a she.
Great question. It doesn't seem to have that
information, but we can presume it's maybe a few years on.
We can't all be girls. We've got to have a male in the mix here too.
Anyway, this young person was diagnosed with diabetes at the age of 20 when their HbA1c was 9.7%. And looking at the diagnosis blood tests they give us, this person was having an episode of acute pancreatitis when they were diagnosed with a sky-high lipase. So they've had a number of episodes of acute pancreatitis, 5 admissions in the preceding 12 months. There's a question mark about the etiology, but of course the next line is the recurrent alcohol binge drinking, which could be related, but they say not always temporary related to pancreatitis. I am presuming they've ruled out gallstones. Dyslipidemia with a low HDL in the overweight category, and with that waist to height ratio actually puts her in the significant sort of obese kind of range there. So we have a young person here with who has features or who has risks for diabetes of the exocrine pancreas, looking at those episodes of acute pancreatitis, but also has features suggestive of type 2 diabetes as a cause for their diabetes. I wasn't quite sure what to make of the C-peptide and the fasting insulin there, because first of all, we weren't given a matching glucose, which you'd always sort of want to interpret those. And then the C-peptide was at the lower end of normal, whereas the insulin was high. So usually the ratio is 1-to-1, but it is possible that this person had received some insulin in hospital, which would be picked up on that insulin assay. The liver function tests are abnormal. They have acanthosis nigricans, which once again sort of makes you think insulin resistance type 2 diabetes. The pancreatic antibodies are negative, which we would say sort of would exclude type 1 diabetes. As to what might be causing her acute pancreatitis, so things we'd have to consider is, alcohol might be implicated, but they've said not always related. So they haven't told us on this slide what her triglycerides are. So severe triglyceridemia can precipitate acute pancreatitis, as can hypercalcemia, but I'm assuming she doesn't have that. And then there is a genetic form of pancreatitis. So, does she have a family history of pancreatitis? And there are actually some genetic tests you can do. So, you know, those would be things we'd have to sort of think of if we're not entirely convinced that alcohol has played the role here. And as I said, I hope they've ruled out cholelithiasis or gallstones. Yeah, so there we have a young lady with, just looking at her results here. The cause of her diabetes, right as we sit and look at this slide, currently is unknown. So whether she has type 2 diabetes or whether she now has acquired an additional insulin deficiency from the current acute pancreatitis. So looking forward to what happens next. Okay, so she lives in a regional town, unstable housing, often long grassing, food insecurity, alcohol dependence, history of domestic violence, history of STIs. So a very vulnerable person, a person at risk of many things. I would quite understand if it also told me that she wasn't really taking any medication or engaged with her healthcare. And then she has quite a strong family history of diabetes there, and an older sister. I just can't quite see what that says. Older sister diagnosed at the age of 17. Yeah, so, you know, if I saw that combination, I'd like to know what age her parents were diagnosed at, but in the non-Indigenous group of people, when we see this, sometimes we do wonder about MODY, and in the Indigenous group of people, I don't think we test for MODY that often. I mean, this young lady's clearly got sort of features of insulin resistance. But when you have a really strong history of people developing diabetes at a young age, MODY always has to come up as a consideration. I think she's going to be one of the two types that we've already spoken about, or more sort of a mixed phenotype. But I just wanted to put it out there that, you know, MODY is something we should sometimes consider. The genetic testing is expensive. There is a study in Melbourne, and I'm not quite sure of all the details, but you can sometimes get the genetic testing done through them for free. Why should we know about it? Is because some of those MODY groups respond really well to sulfonylureas, which we tend to try to use as sort of third line or even lower agents in this age group. So, you know, that might be the benefit there. Okay, so poorly controlled diabetes, abnormal liver function tests. She does not, still haven't told us the triglycerides, but we presuming they're not abnormally high. She's in the BMI overweight category, but she may actually be, because she's Indigenous, she might actually be, you know, more overweight than based on her BMI. She's got hypertension and she also smokes. So once again, some of those features like the overweight, obesity, and the hypertension would make you think more of a type 2 diabetes kind of phenotype based on the information that's on this slide. She's probably got fatty liver as well based on her liver function tests, although I'd usually expect the GGT and the ALT to be a bit high. And we know vitamin D deficiency is very common in Indigenous people overall and might be relevant in her case, but that might explain the ALT. So I'd want to see that she's at least had an ultrasound of the liver to see what's going on there. Okay, so she does not have proteinuria, so empagliflozin is really not a priority medication for her. perindopril would be for her blood pressure, and then metformin, but she clearly requires additional medication if we manage to engage and get her into a position where she's willing to, or willing to take some medication. And there might be some that are contraindicated depending on the next slide.
Okay, so Eleanor, you've talked us a little bit through what the diagnosis is, and there's a little bit, it sounds like a little bit of uncertainty in terms of the information that you've provided. So what investigations would you be ordering to help get a little bit more confidence in making a diagnosis here?
Okay, so I would, to clarify her sort of her type of diabetes, and as I say, she may have a mixed phenotype. So I would definitely want a C-peptide with the matched glucose, and I want the glucose to be above 10 because I want to sort of challenge the pancreas and see how much endogenous insulin it can make. I'd also want a fecal elastase because if that is low, then that very much supports that she that she's got sort of insulin deficiencies and exocrine pancreatic insufficiency is part of her phenotype. And then we do sometimes test for the fat soluble vitamins, but as I said, vitamin D deficiency is really quite common, and I'm not sort of in the habit of testing for the other ones because they may be quite expensive. So those would be the ones that I would do to try and clarify, what are the best medication options for managing her diabetes.
And can I ask you a follow-up, Eleanor? How would this change your management depending on which diagnosis you ended up coming up with?
Okay, so let's say she does turn out to have a low C-peptide plus or minus a low fecal elastase, then I would go, okay, this woman, she may be insulin resistant, but she also has insulin deficiency. So that means that insulin is really one of the is an essential part of her diabetes treatment. She with metformin and potentially an SGLT2 inhibitor if she's with caution, if she's really managing her insulin very well. If her fecal elastase is low, then she'd need Creon. And I sort of don't really even delve into asking people whether they've got steatorrhea or what color bowel motions, because I just find the history is quite inaccurate and it's quite a hard thing to talk to people about. So, the test is very easy to do. It can be done in remote communities. Doesn't need any sort of special ways of getting it to a lab. So that is quite reliable. So as suggested by her, her acanthosis nigricans, her hypertension, her liver function tests, all of the lipid profile with a low HDL, if she also has an element of insulin resistance, then I would suspect that her insulin doses required would be higher than in someone who has a pure sort of diabetes of the exocrine pancreas, because we know they're pretty insulin sensitive, needing about 0.25 to 0.5 units of insulin per kilogram body weight per day. I suspect she might need more if she has that sort of combined combination of what should I say, features to her diabetes.
Thanks, Eleanor. Emma, I'll pass over to you. As a GP and you're looking at the whole picture of this patient, what would be your priorities of care for the healthcare team?
I'm not sure how to interpret for the team, but some of the thoughts that come to mind are we're potentially dealing with a patient who needs insulin but has very unstable housing and social circumstances. So I'd be really concerned about the risk of hypoglycemia balanced against the risk of ongoing hyperglycemia. And in the past, I've seen these cases have a lot of recurrent presentations to hospital in extremis, perhaps with future pancreatitis, hypoglycemic emergencies. And so whilst from a primary care perspective, we would appreciate all of those details in an endocrinology plan and potentially not be making too many specific initial management decisions ourselves. It's an indication there that she has an alcohol dependence issue at the moment, and it may be that the primary care team's greatest contribution will be exploring options to reduce some of those background risk factors that will otherwise make her management almost impossible to safely achieve, I would say.
Thanks, Emma. And Jamie, your background as a diabetes educator and pharmacist, how would you look at this case here with the details that we've got and approach it?
So she's not on, they are not on very many medications. I'd be looking at why. So, you know, the social circumstances imply that medication's not really a priority. So is that why there's not many things prescribed? Was that just decided that that would be the best option for the circumstances? Or are there other reasons, like, you know, how could we support them to have insulin? So within Worley, for clients like these, we have a community services program that deals with homelessness and hospital presentations. So, you know, getting them involved in that would help the clinical team be able to support them in their medication management. But yeah, I mean, insulin definitely would be a priority, but what are the realities of them actually having it and having it safely, taking it, all that sort of stuff. But yeah, it does seem to be on very minimal medications given the severity of the glucose management, or the glucose control being pretty bad.
And Cheryl, what type of engagement strategies would you employ here?
Yeah, a bit of a tricky one, particularly with mixed phenotype or hybrid type of diabetes. But yeah, realistically, we'd have to try and see if we can get this person to engage with whatever local clinic it might be. So if it was Dunella-Dilbar, whatever the closest Dunella-Dilbar clinic was, and then try and get them to follow up with services like care coordinators. So trying to highlight this type of patient, again, complex, get them into the clinic. Care coordination generally can't happen until they've come in and they've seen a doctor and had care planning done. So there's always roundabout ways to get to that, but trying to get this person in, and again, being a bit of a traffic director, seeing if they're try and sort out some sort of stable housing, because long grassing really isn't ideal because it's exposing to domestic violence, continuing alcohol, history of STIs. I mean, I've seen this type of patient before, and they are definitely keen to try and get out of the situation that they're in, but it can be difficult, but there are services available. So just directing people into those services and trying to get them to come in, and just again building rapport and asking them, because I am leaning towards pancreatic type of diabetes, so asking about their eating patterns and food and what their bowel movements might be looking like, because if there is an opportunity to use Creon, depending on what the fecal elastase is, of course, but it could make life a bit more comfortable if the bowels aren't looking good. But again, maybe some imaging of what the pancreas is looking like or what the liver's looking like too. So yeah, just trying to build rapport and trying to bring the whole picture together. and definitely referring to endocrinology, making sure this person has got, you know, specialist endocrinology service and LinkedIn. Yeah, I think that's about me. So there might be NDIS too, would be available. So we're talking about a regional service. So NDIS, which is also available in places like Maningrida and smaller places, but in the regional, hopefully, for example, with Danella Dilba, they do have care coordinators allocated for each clinic. But again, it's not that easy. Sometimes there's some hurdles to jump to try and get that person in. They might be moving around transient. Yeah.
Thanks, Cheryl. And Emma, can I just pass over to you as a GP from a primary care perspective? What services would you be looking at that might be available to help someone with this type of social circumstances?
I think it's very regional specific. Probably what I think in this case, my first thought would be to match the services to the patient express priorities at the start. She's been hyperglycemic for a long time and it is an important priority, but the insecure housing, the risk of violence and those other issues are likely to present as a more urgent priority as they would for me if I was facing them. So I would hope that by identifying the patient priorities and refer to them, and they may be non-health agencies. I think there's probably a lot of non-health agencies here that better meet the patient-specific priorities, financial agencies, social support agencies. So and that would be very dependent on what's available. But I would probably start there, try to demonstrate our the support of the patient holistically and not just chase the HbA1c maybe at the first meeting. And I think this is a good example of how there's a gap between your ideal approach as a medical professional and your pragmatic approach as a human being to what is really a really complex scenario and playing the long game in terms of supporting the patient.
Really good points. Just pass over to the rest of the panel before we wrap up. Any final thoughts on this case or anything else that we've discussed today?
One of the things that we've started to see, so we set up in our clinic a support group for young people with diabetes, but this sort of highlights there's a cohort of people that would have been part of our youth support group if it existed when they were diagnosed, but now they're sort of a bit too old for the dynamic, you know, the categories that we set. So is there a way that we can engage them the same way we would have if they were younger, but now they're a bit older? We haven't quite found a way to do that, but something to think about, that they would have accessed our support group if it existed. Now they're sort of more young adults. Can we employ the same sort of strategies to get them engaged? Like how do we get them involved even though they're not sort of in that youth diabetes category anymore? We don't really have a solution, but it's something we're talking about.
It's a great point. It can be so difficult to find those people that just don't fit nicely into the service boxes that we've got sometimes, isn't it?
Yeah.
Yeah.
Any final? Yeah.
You know, the sad thing is that a lot of these young people have got such challenging social situations, and sometimes our child youth outreach program are involved and support them until they're 16, and then they disappear off the radar. And the next time, I had 3 GPs contact me last week. 10 years down the line, they disappear, and then a few years down the line. So these are 3 young women between the age of 20 and 30 who now all have significant complications from their diabetes and, you know, staring down the barrel of dialysis like now. So, yeah, I think if we could find a way of you know, engaging and empowering that age group, we would make such an impact on their quality of life and you know, outcomes for those young people. So it's actually really, yeah, I had to stop last week and just go, oh my gosh, you know, this is going to get a lot worse before it gets better, but we can just keep trying.
It is going to get a lot worse, and we know that the outcomes are going to be a lot worse, and we're all seeing it and watching it like a slow moving freight train going off the rails. I'd like to see something like a RHD register, that we can at least monitor some of these people, like young people transitioning even to adult practice, even if it was just up to the age of 25 or something, just to, as a priority, because we know things are getting worse, and the bodies are just so young and they just get more damage. Young people will get more damage from the effects of diabetes than, say, an older person. So we know all of this, and I would suggest if there's any way that we can get a register, because like I said, I've seen these kids go from a very small community and then I run into them in Derby. There's movement, and even the one young girl that I ran into in Broome, she hadn't been seen for I think it was up to 6 years, and she was just out of control. Sadly.
It seems like well coordinated follow-ups really important.
It's difficult.
Yeah, definitely. Emma, any final thought from yourself?
Only that these are 3 really complex cases, and I know many people dialed in will be used to them and familiar with complex cases, but I think it's okay to feel overwhelmed by cases like these, because it's challenging to achieve the level of care that we want for them, and I think we've all felt that way from time to time.
Yeah. Okay, well, we'll finish up there, and I just want to thank Eleanor, Cheryl, Emma, Jamie. Thank you so much for being involved. We really appreciate it. Having you guys on as panelists has just been fantastic. These wouldn't happen without you taking the time out of your days to do this. So it's really generated some great discussion. We've had excellent engagement in all of our case studies, and it exists as a resource that lasts after this, that people can watch if they've got questions about managing youth type 2, because as you've mentioned, it's something that we're going to start seeing much more of, and it's important that people have information on, I guess, how to not only manage things from the medical side, but also look at the multidisciplinary and holistic care that we can provide these, you know, so commonly complex cases. So I want to thank everyone for being involved as participants as well. It's been brilliant to have so many people sign up. We've had almost 330 people sign up for this, which is excellent. So we'll post this to YouTube afterwards. We've also got a feedback survey that I'll email out to everyone. It'll take a couple minutes, couple of items that we'd really like to get some information on so that we can help properly evaluate this. So thank you to everyone who's been involved. It's been excellent. And please, if you've got any questions that exist after this, please reach out to us and give us an email. Thank you.
Thank you.